This is the stellate ganglion block. Is used for the treatment of many medical conditions, including complications and peripheral vascular disease. It is found on each side of the neck by the fusion of inferior cervical ganglion, which is a sympathetic ganglion, with the first, occasionally second thoracic ganglion. The anatomical relations are anteriorly it may have subcutaneous tissue, sternocleidomastoid muscle, subclavian artery, and carotid sheath. Posteriorly, it is lying on the anterior scalene muscle and sheath of the brachial plexus, neck of the first rib, transverse process of C7, which is vertebral artery and longus colli muscle. Laterally, it lands on the superior intercostal vein and superior intercostal artery. Medially, it has the prevertebral fascia, vertebral body of C7, esophagus and thoracic duct. Inferiorly, pleura, dome over the lungs apex. So that's all this relationship here. So this is the stellate ganglion. You can see between the T7 and T1 vertebra, very close to that. That's this is the location where it is there. And these are the brachial plexus nerve fibers. And this is the sympathetic chain coming from above. So there are three ganglia, superior, middle, and inferior cervical ganglia. So the fusion of this inferior cervical with the first thoracic or second thoracic ganglia is called the stellate. Stellate means star-like. So you see, actually, because of all these connections, it looks like a star and star. And that is the reason why it is called that. Now, what is the indication? Mainly for chronic pain conditions relief. So it is used by pain physicians nowadays for relief of chronic pain conditions like chronic regional pain syndrome 1 and 2, herpes zoster, post-herpetic neuralgia, refractory chest pain, angina, phantom limb pain is another important indication. Those who have got amputated upper limb, they suffer from phantom limb pain, and that is very much relieved by this stellate ganglion block. So two important indications you have to remember is one is CRPS and another phantom limb pain, and the third thing will be post-herpetic pain. And this indication was earlier tried, the refractory chest pain on angina, but nowadays we don't recommend that. So just for theory exam sake, you can write that, but in practice, these three conditions are the main indications for stellate ganglion block. Then vascular disorders of the upper limb like Raynaud's phenomena, obliterative vasculitis, vasospasm due to intra-arterial injection of thiopental. This is where that condition comes. And scleroderma, trauma, embolic phenomena, frostbites. All those conditions where the vessels go into an acute spasm because sympathetic blockade will cause vasodilatation. This is the mechanism why we use this in vascular disorders. Now, contraindications, patients who had a recent myocardial infarction, patients who had anticoagulated therapy, the possibility of coagulopathy, glaucoma, and phrenic nerve palsy, all those things, this has to be avoided. The techniques of stellate ganglion block, there are 4 techniques. First technique is the simple landmark technique, where you keep the patient in supine position with slight extension of the head and then turn it to the opposite side. So this is how the extension is achieved by giving a double roll under the neck, and then anterior part of the neck is painted and draped. Muscle and artery are pushed laterally, and then palpate the shining tubercle in the transverse process of the 6th vertebra. And this is how you palpate that. Then skin and subcutaneous tissue are pressed firmly onto this tubercle, and needle is directed medially and inferiorly towards the body of the 6th vertebra to hit it, and then withdraw 1 to 2 millimeter to rest outside the longus colli muscle. So actually what you can do is you can go and hit that transverse process of the 6th and then withdraw 1 or 2 millimeters, and the needle will be on the longus colli muscle, over which only this ganglion is lying there. So depositing about 5 to 10 ml will cover this ganglia easily without any problem. So inject 10 ml of 0.25% levobutyrogen after test dose and negative aspiration for blood to rule out any intravascular placement. Then second technique is what is called the fluoroscopic technique, which is outdated now. Earlier we used to do that by using the C-arm, which is used by the orthopedic surgeons mainly. That is called the fluoroscopic research, and that can be done using the C-arm. And you can use a radio by contrast to see the spread and then inject the drug in that location. So the picture will look like that. When you see the fluoroscopic view, first you do the contrast here. You will see that it is spreading over that longus colli muscle, and this is a needle direction which is coming here. And once the contrast is staying like this, immediately you follow it up with the local anesthetic injection. The third thing is the CT guided, where you have to take the patient to the CT scan and then put the patient there. And here you can see nicely the vertebra, the transverse process, the first rib, everything can be seen, and you can direct the needle under CT guidance and go to the exact location and then inject the solution. Easiest and the most common thing used nowadays is ultrasound guided. So this is placed at the neck at the level of C6 to enable cross-sectional view. So we can see this is the ultrasound probe which is being used, and you are using the needle. The patient's head is turned to the opposite side, and this is the inline insertion. So once you go there, these are all the structures you will be able to see. So more superficially, it will be sternocleidomastoid dermastoid. Then you go to carotid artery, IJV, and this is the longus colli muscle. So under the carotid artery and above the longus colli muscle, you have to deposit the solution here. And this is another close-up view of the medial and lateral. So longus colli muscle, just on the surface of the longus colli muscle, you have to deposit the whole solution. The complications, as we said, Horner syndrome, vascular injuries, neurological injuries, pneumothorax because the pleural dome is very close, and intravascular injections, all these things can happen. Local anesthetic toxicity and infection are all the complications that have been mentioned. So this is more or less exactly what that means Dr. IL has presented. Except for the historical event of intravascular type 1 injection, there's nothing more to add in that.